So here's the outline of my presentation. I will go over the dosimetry and treatment planning aspects of thoracic treatments. So first I'll go over simulation, then I'll go over contouring, contouring targets and OARs, conventional fractionated radiation therapy and SABR plan setup, optimization, and then finally treatment. Okay, so with this slide, I'm showing the challenge in thoracic radiation therapy, and this is a slide taken from Dr. Liu's talk before. So you can see with motion inclusive on the far left, you're treating a large volume of the tumor as it moves up and down, so you're giving excessive radiation dose to normal organs. With gated treatment, it's better, so you're only treating when the tumor is within the target. But this does take more time to treat. And finally, on the right with track treatment, the beam sort of follows the target, and this is a newer technology I'll discuss in the next slide. So for most of the treatments up to about last year and earlier this year, we used variant true beam to treat lung treatments for conventional and SABR. That's able to do gated and breath hold and motion inclusive treatment. Then just recently this year, earlier this summer, Natalia, Dr. Liu, and Daniel and other members of the team did a ton of work on this. We have the reflection LINAC that's able to do biologically guided treatments. So it's able to track the PET avid lung tumor and sort of do the minimum amount of dose to the normal tissues. So it's better, less side effects for the patients. Okay. So for this slide, we're going to talk about simulation. So patients are really on a sort of like a wing board. The arms are up above overhead if they can tolerate it. If patients can't tolerate it, it's okay to have arms down, especially on the contralateral side where the tumor isn't located. The Xi Ford is really used as the isocenter, the CT origination for the BBs. And these patients are almost always simulated using a 4D CT. So you can see, so there's a IR camera that's sort of directed as an IR markers that's placed on the patient's chest. And as the patient's chest moves up and down when the patient breathes, this IR camera can kind of track the motion and record the location of the IR markers. And this gives us a breathing cycle. So 0% would be the max inspiration, 50% is max expiration, and then it goes back to 90% and 0%. So for gated treatments, if the tumor motion is large, for instance, if the tumor is close to the diaphragm, there's a lot of movement, and the patient is able to follow these breath hold instructions, then inspiration breath hold would be a very good option. Whereas for patients that cannot follow these breath hold instructions, often patients are very sick and they can't hold their breath, then we would do expiration. So from the 30% to the 70%, that's the time the tumor will spend the most amount of time within target. And here's showing a video of the RPM system recording the IR marker moving up and down the patient's chest. Okay. So for planning scan selection, so depending on the motion management capabilities and the tracking capabilities, the target volume can be very different. So here it's showing that this tumor, sorry, my mouse cursor. Okay, so let me play the video. So this GTV is contoured initially on the 50% face, and then it's also contoured other phases, and then combined to create an ITV, or internal tumor volume. Now on top of that, we'll add generally a 5 millimeter expansion to create a PTV. In this diagram down here, we're demonstrating that with BGRT, so with the reflection technology, we're able to use a smaller PTV, and so for instance, 8.8 cc for a BGRT PTV compared to a traditional exhale-gated 14.2 cc or 19.3 cc. All right, now let's go over some contouring. So the physician, for instance, Dr. Lu will contour the GTV and then create, based on the GTV, contour on the other faces to create the ITV, use an expansion to give us a PTV, and also a shell structure, especially for saber treatments. We're very concerned about those fall off. So generally, we want within 2 cm of the PTV, we want the dose to be less than about 55%. With limbus, I believe Ukraine also has limbus now. We actually got it after you guys. The limbus system is very helpful in doing a lot of the OARs for us. Some things to note: chest wall is about a 2 cm ring around the lungs. Limbus sometimes have trouble with esophagus contour, especially if there's contrast. We have to manually edit that. But for the most part, I've had very good results with limbus contours for lung treatments. Okay, so these are slides that I included in this PowerPoint, and you can get a PowerPoint from Natalia. So I won't read everything. You can look at the slides later for detail. But generally, conventional fraction reduction therapy is 66 gray and 30 fractions. If there's a lot of overlap with esophagus, we might sometimes have a lower dose volume, so it'll be dose painting. The region that overlaps with esophagus might only get 60 gray instead of 66 gray. And then for saber prescriptions, a lot of the treatments we do are 25 gray in 1, but depending on the location and the size of the tumor, we do other fractionations as well. 25 in 1 is generally where the tumor is small and not centrally located. And for saber treatments, we want these plants to be very hot. So generally the center of the GTV, we want it to be at least 120%. We've gone as high as 140%. For beam setup, plant setup, conventional fractionation radiation therapy, we generally use 2 fields, occasionally 3. For saber, we try to stick to 1 because the length of the treatment is very long. The patient is on the table and sometimes they have to do breath hold, so we want to minimize motion. Both of these tend to be partial arcs, and collimation generally 340 and 10 degree, but sometimes I'll use 80 degree instead of 10 for the second arc. For instance, for conventional, if you look at this diagram, the PTV kind of separates. There's a superior middle portion, inferior portion. So when you have a 80 degree angle and you can close the jaw, for instance, to reduce the amount of overlap between the PTVs, amount of overlapping dose fall off. Energy is generally 10x for conventional. If it's a very small PTV, we can also use 10x FFF. For SBRT, we use 10x. And those algorithm is actuals. Right. Objectives. So for conventional, the goal of the treatment is sort of have a uniform dose. We want to, as I mentioned, avoid a lot of dose in the esophagus. These tumors tend to be centrally located. We don't want the prescription dose to cover the esophagus. And generally, if we're able to, we want the 55 gray isodose line to not cover the esophagus. Besides esophagus, the other objective is just balance among the lung dose with heart and core dose, as well as covering the PTV. For saber, we're doing ablation of the GTV, so very precise and high dose treatment. OARs are further away So as I mentioned earlier, we want to avoid low dose pillage. So greater than 2 cm away from the PTV, we want the dose to fall off to under 55% generally. We're going to keep the GTV hot for GTV ablation. And we want to generally avoid 105 to 110 hotspots in the overlap areas in the chest wall or airways. These are the plan objectives. Again, I included, they might be a little bit small for you to read, but I included it in PowerPoint so that you can refer to it later. These are the Stanford planning objectives for the organs at risk. Some important one is the lung. Generally, we want to look at the lung mean and the V20. Those are probably the two most important ones. The spinal cord, obviously, and then esophagus. And also lately, we've also been very concerned about the LAD dose. So that's something that's been more at focus for institutions nationwide. These are the SABRE objectives. So there's a lot on there. A lot of these are non-relevant. For instance, we very rarely will look at liver because it's outside of the field. But I include this in the slide so you can refer to it. So for optimization structures, this would be a typical SABRE case of a very small tumor that's next to the chest wall. I included how I would create these tuning structures. In the interest of time, we're already at 12:58. I won't really go over these with you, but you can refer to the slide at a later point. The idea is we want to create this tuning structure that's modified from the GTV and off of the chest wall and lung. Off of the chest wall and the periphery of the PTV. And I'll just like during planning really push those into the wide structure, the center structure. These are the values I'll use by default, and then I'll add more OARs depending on the location of the tumor. For plan evaluation, I'm highlighting some of the OARs we typically look at. For instance, for this 25 Gray case, I highlighted here that the shell is receiving. The shell is receiving max dose of 56%. So generally we want to get about 55, 56%, and absolutely want to keep under 65%. That's sort of our limit. All right, so now, so pre-treatment, we'll do these floor imaging. Here's a video. So after KV match is acquired, we'll do these flow imaging for amplitude gated treatments. And then this allows us to adjust the gating window. Okay, here's the image. So here's another video. So during the treatment, we can do trigger imaging to verify the location of the tumor. And if the tumor is outside, then we can pause the treatment and sort of realign and verify the location again. And here, just very quickly, a video of the gantry rotation. On the left is expiration gated, and on the right is inspiration. So inspiration breath hold generally takes longer, and that's why we reserve it for patients that have very coachable breathing patterns. And with that, I'll leave time for questions for myself and Dr. Lu.
Excellent. Thank you so much, Zhi. It was a great presentation. I will open the floor for questions. Sergey, you wanted to ask question?
Yes, I have one question regarding planning. Do you somehow control aperture shape? So do you use some controller for that, especially for small tumors located somewhere where they are moving fast, so in a lower part of the lung? Or maybe,
yeah.
or
Zee,
maybe,
do you want to
yeah,
take that one?
Also kind of check afterwards the opening for the leaves.
All right, could you just very quickly repeat the question?
He's asking about aperture shape controller. So I think a good way to answer this, we use this technique of doing a conformal arc first. So with most of the MLCs opened, and then we can start VMAT plan using that base dose from that conformal arc. So then it's only slightly modulate. So we keep the modulation factor low, and that also controls the aperture size.
And in Eclipse, there's a tool dropdown in the dropdown menu for shape field geometry, and I generally for these saber treatments shape it to within 2 millimeter to up to 3 millimeter of the PTV. And then also within the optimization, you can set the max MU. We generally set it to about 2x of the prescription. So for instance, for 25 gray, I'll set it to 5,000 MUs.
There is also aperture shape controller. It's just, I don't know numerical values, but it's high, low, moderate, something like that. Do you also use that one?
We don't usually use it. We rarely use it.
Not used.
Yeah.
Okay. Thank
you.
you.
But there's an option. Yeah, great. Thank you. Great question. Any other questions? Dr. Lu, I'll ask a question then. Okay, so for you mentioned that now we can treat with Saber stage 1 to 4, but you have to exclude stages 2 to 3, no?
Yeah, so we're not doing that routinely. For example, our locally advanced chemoradiation. However, having said that, there's actually an RTOG, or energy oncology trial now that is doing Saber to the primary tumor and fractionated treatment to the nodes. So it may be it's a paradigm that's being explored, and there's been a few variations on that, but it's not routine at this point.
Can you please comment on the motion management? How did you start with motion management? Because at the time you started as a BRT or Saber here, there were no very good tools, right, that were commercially available. And that's something where Ukraine is. They don't have the tools for motion management, and how they can start doing SBRT.
Sure. Well, I mean, there's of course multiple different ways to do motion management, and I think they all take some learning to use. And so, for example, we never really implemented seriously like abdominal compression here. Some centers are very big fans of abdominal compression. And that's because it takes, a certain amount of learning to really optimize and do it right. And so there are centers that have invested in doing that. At our center, we invested more along the path of really optimizing our gating techniques. And so that's kind of the direction that we went. So I think it sort of requires kind of picking a technique and just learning how to do it really well. And so there's some a certain degree of choice there as far as deciding like what technologies you have accessible, what personnel you have, and where you want to invest your time in learning it. So we went down the path of optimizing our image-guided techniques, bringing in the fluoroscopy for verification of the gating techniques. Most of our patients, we do just because for most lung tumors, the motion isn't that big. So 4D CT is useful for just characterizing what the motion is and then defining a motion inclusive target. And so most patients are treated that way. We kind of just target the range of motion using a 4D CT assisted target definition. But for the ones that require a more sophisticated motion management, we kind of went through the process of implementing breath hold and providing biofeedback to the patients to assist the patient, as well as the free breathing gating techniques. So I think it requires assessing what technology you have and where to invest the time and kind of learning to optimize it.
Thank you. Any other questions from the audience? Or Ruslan, do you want to ask a question?
Hello, my name is Mazalinsky. I'm a medical physicist, and my question is about energy. I saw that you used only 10 MV. What is the advantage and disadvantage of this? What you can say? Thank you.
Bill, do you want to answer or?
Sorry, I had a little trouble catching the question.
Oh, yeah, the question was about using 10x FFF, and why we use 10x FFF.
Sure. So the primary reason we use the 10x FFF is for the treatment speed, because particularly when we're doing either gating or breath hold techniques, it's important to minimize the treatment durations. That's the main reason. The thing that we had to do to be comfortable with using it and trusting the dosimetry was implementing and commissioning the Acuros dose calculation, because with the higher energy beam, there's more concern about the correct heterogeneity corrections in heterogeneous tissues like the lung and tumor interfaces. So we validated the Acuros dose calculation for 10x before committing to using it.
But Ruslan, the differences in dose rate are very drastic. For 10x FFF, it's 2400 MU per minute. So it's very, very fast. Compared to 6x FFF, it's half of that value.
Yeah, thank you.
Any questions? Any more questions? Any clinical questions? No? Okay. So thank you so much for a great session. It was really amazing. Thank you for preparing the talks. And our next session will be on Friday, and it's going to be on sarcoma. So see you there. Bye.
Bye. Thank you.
Thank you.